Our next speaker is Consultant General Surgery and Laparoscopic Surgeon from Armed Forces Hospital Southern Region, Dr. Hesham Haroun. He will be presenting failure of component separation and how to avoid it. Thank you for coming, Dr. Haroun.
Thank you very much for inviting me for this opportunity. Bismillah ar-Rahman ar-Rahim. Component separation, all of us know that the outcome of hernia surgery worldwide is not satisfactory. That's why the need for a hernia specialist team are now, some centers are calling for this, a hernia specialist surgeon, a specialist plastic surgeon, and technician, assistant, like that, to reduce the complications of hernia. Some cases even come to you for the fourth or fifth or sixth time to do a hernia, abdominal wall hernia surgery. Component separation first created by Ramirez 1990s, and then after that modified more than one time to add even mesh in the repair, instead of to be done without mesh repair before. It is just mobilization of one of the abdominal wall components to cover a big defect. There is a lot of complications like infection, recurrence, ischemia, necrosis, seroma, venous thromboembolism, and delayed healing and fistula. And to avoid these complications, you have to go choose the proper indication, if this patient indicated for component separation or not. So the indications for component separation, the large wall defects, relief of tension, placement of mesh, and loss of domain. To know these patients have loss of domain or not, so you have to do CT volumetry and check the hernial sac volume in comparison to the total peritoneal cavity volume. If it is more than 20%, so this patient have a loss of domain and most probably will need some sort of component separation. And here how to calculate the volume, craniocaudal, anteroposterior and transverse diameter. And then you calculate the total peritoneal cavity, including the hernia, and then you divide the hernial sac over this calculation. And here, a picture of a CT, sagittal and axial cuts show the distance from the hernial borders and how to measure. Again, here the abdominal cavity and how to take the dimensions. Sorry. Another measure to measure the patient need component separation or not is rectus to defect ratio. If you measure the length of the rectus muscle right and left, then divide this calculation to the defect diameter. If it is more than 2, so routine surgical repair will be enough. If it is less than 1, so most probably this patient will need some sort of component separation. Between most of the 50% of the cases, less than 1.5 of the repairs, additional component separation technique is required. And here, for example, this patient doesn't need component separation because the rectus dimension is more than the hernial defect. While here, if you calculate the defect to the sum of the right and left rectus, so most probably this patient will need component separation. So planning of surgery is very important. But is there a contraindication to do component separation? Yes, also there is some cases you don't need to do component separation, not all the cases. If the patient have significant abdominal wall loss, may require bridging repair, component separation will not be wise to be done. If there is edema, inflammation, severe infection, a patient in acute condition, laparotomy, or a small defect doesn't need, or subxiphoid or defect, or suprapubic defect, which may not provide enough mobility for closure, and permanent mesh is not contraindicated. The second issue is to plan well for your surgery, to prepare the patient properly. Preoperative factors of the patient, cessation of smoking and malnutrition, cardiac, pulmonary, diabetes, all the factors, and do CT and CT volumetry, and immediate preoperative preparation and postoperative care, very important also. I will not go to the solid knowledge of the anatomy of the abdominal wall, but all of the surgeons working in hernia should know about the solid knowledge of the anatomy, superficial fascia and the rich blood supply, and external oblique insertion and origin insertion and its dimensions, the internal oblique, and in addition transversus abdominis, rectus abdominis muscle, and rectus sheath as well, and linea alba, and the blood supply of the abdominal wall, very important to know the origin and anatomy, and in addition to the nerve supply, which is very important, because this issue will help you during your procedure to avoid complications and recurrence. Don't hesitate to use adjuncts, as our colleagues talk about the pneumatic and botulinum toxin. Very important, if you have a patient, don't rush to the surgery before you prepare him well. If he needs Botox injection 1 or 2 months before surgery. And in addition, loss of weight is very important. Loss of weight is very important. Even some cases need sleeve gastrectomy before surgery to prepare the patient for abdominal wall reconstruction. And there is cases proved that after a sleeve gastrectomy, the defect reduced and the patient became easily to close the defect. I will not talk about botulinum toxin and how to do, because some colleagues will talk about this. But if you see this picture, you will find that it is very beneficial and fruitful prior to abdominal wall component separation. And pneumatic compression as well. Some people, it doesn't like because it causes some discomfort to some of the patients, and technically need high technical experience to insert and inflate, but also it has a successful results. The technique is very important. You need to prepare your setup and your team, and to choose before surgery what you will do, or retrorectus repair, anterior or posterior component separation. If hernia less than 7 centimeters wide, can typically be repaired without any component separation, and if doesn't need component separation, you don't need to do it, because it definitely make weakness to the anterior abdominal wall. From 7 to 10 centimeters wide, just check by rectus defect ratio. If more than 10 centimeters wide, use component separation technique. Please don't use anterior or posterior component separation together. It is almost contraindicated. Further, myofascial release should be avoided once tension-free is achieved. There is some tricks during the anterior component separation. As you know, the original Ramirez component separation technique was no mesh, but now there is mesh should be integral part of the modern large complex hernias. The most important, what I want to concentrate on in the anterior component separation, the periumbilical perforator sparing technique, because this one will avoid the complication of the wound and the seroma infection and the recurrence. And there is a way how to do these bridging techniques. And the placement of mesh can be on lay retrorectus if the defect less than 12 centimeters, interperitoneally IBOM if defect more than 12 centimeters. Don't forget to put 2 drains. And this is a way how the periumbilical perforator sparing bridges and the tunnels should be created, and continue your dissection like that. As you see here, the perforator sparing technique and the neurovascular bundles spared. In the posterior component separation, techniques should include Rives stoppa retrorectus dissection, transversus abdominis release, and the posterior lamella of the interior oblique can be divided just medial to the linea semilunaris to avoid neurovascular bundle injury. And the TAR allows myofascial relaxation in addition to well-vascularized retromuscular pocket for mesh placement. Again, the Rives stoppa, the neurovascular bundle mark the lateral extent of the retrorectus space, so you don't need to reach to that level, at the linea semilunaris. And traditionally, TAR was described by very large ventral hernia, now often being adopted for smaller hernias. So we avoid tension now in hernia repair. Avoid peritoneal holes and utilize the omentum to close this one. Avoid peeling off all fats from the muscles. Traveling under the costal margin will give you impression that you are in the right plane. If you reach under the costal margin while doing the dissection up, liberation of the whole peritoneum from the diaphragm till space of radius is important, will allow better closure, and complete dissection of the lateral periperitoneal plane into the retroperitoneum to expose the psoas muscle as well into the space of radius and retroxiphoid space to the central tendon of the diaphragm is very important. I will not talk about this, but the mesh placement and the closure is very important. All of us know that the posterior rectus sheath closed with absorbable suture. Underlying omentum utilized, as we said, to close the defects in the peritoneum, and uncoated monofilament polypropylene or polyester mesh, large mesh, is secured. The mesh can be directly secured to the Cooper ligament and xiphoid process or the costal margin. And the type of the mesh, there is synthetic and biological and even bio-A meshes. Most probably we use synthetic meshes. Post-operatively, skin and subcutaneous tissue is very important to take care to avoid extensive undermining and obliterate the dead spaces. The entire reconstruction can be lost due to skin necrosis, dehiscence, seroma, and wound infection. So careful handling of the tissues post-operative is very important.
Dr. Hesham, can we wrap it? Because we have less than 30 seconds.
Okay. Proper post-operative management, VTE prophylaxis, abdominal binders, drains, avoid dealing with complications like seroma infection like that. And in summary, what is the points you should concentrate on again to avoid complication and avoid failure of component separation? You should have a clear indication. You should properly plan for your surgery and choose the technique. Solid knowledge about the anatomy. Use of adjuncts is very important. Proper anterior or posterior component separation technical steps and tricks. Choice of suitable mesh and its placement, special care to skin and subcutaneous tissue, post-operative care and management of complications. Thank you very much.